From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, and welcome to our listeners around the world. You're listening to JAMA Oto Author Interviews. Thanks for joining us. I'm your host, Dr. Paul Bryson from the Cleveland Clinic, where I serve as the Section Head of Laryngology and Director of the Voice Center. And I'm delighted today to be joined by Dr. Yaël Bensoussan, who's an Assistant Professor and Chief of the Division of Laryngology and Director of the University of South Florida's Voice Center within the Department of Otolaryngology Head and Neck Surgery. I'm also joined by her colleague and co-researcher, Dr. Victoria Sanchez. She is an audiologist, and she is an associate professor also within the Department of Otolaryngology Head and Neck Surgery, and she is the chief of the audiology section. So welcome to you both.
Thank you. Really happy to be here.
So happy to be here. Great to meet you.
And this is, a special welcome back to Dr. Bensoussan. This is almost becoming a series highlighting innovative work in the voice and now hearing biomarker space. And I'm really looking forward to the conversation today. What prompted this is an article that the listener can read further. It's a call to action for why hearing health must be a part of voice biomarker research. To get started, Dr. Bensoussan, would you give the listener just sort of what's the current state of voice biomarker research, as a leader in this field? Tell us where we are right now.
Yeah, of course. So I'm the contact PI and one of the co-investigators of a large consortium called Bridge3i Voice, which is funded by the NIH. And our goal has been to build a large, ethically sourced and diverse data set of human voices linked to health data. Today, we released after 3 years our first thousands of patients, so 1,000 patients across a large set of diseases. And when we release that data, we have to take account a lot of confounders, right? Because we know that somebody with Parkinson's probably could also be dehydrated, and then that affects his voice. So they can be tired or they can be sick. So we make a lot of effort at Bridge3i to try to account from different confounders, like other large studies. But one of the things that we were missing is hearing health. And this is why we started collaborating with Dr. Sanchez and her team to really talk about what we're missing and what it could mean for the accuracy of our data if we don't collect hearing health on these patients.
One of the things that I've heard a little bit about with hearing is that, one, it can impact voice, but I think it's a really nice opportunity. I have a colleague here where it's kind of an underserved sort of vital sign for some of our patients, and particularly those that are aging. Dr. Sanchez, if you could, tell us, why should we care more about hearing health? When we think about longevity and we think about our aging population, can you describe the opportunity here and also kind of what we've been missing?
Yeah, absolutely. And as an audiologist and a hearing scientist, any opportunity to advocate for hearing care and the importance of hearing is just such a great opportunity. To me, both our hearing and our voice allows us to connect, engage, be part of the conversations with our loved ones, with our healthcare providers, and all of those things is really what allows us to have fulfillment of life and be successful in our life, right? So if we're missing a piece of that, if our hearing isn't quite working as well as our voice isn't allowing us to communicate our needs, then we really are at some shortcomings. Hearing loss in general, especially in the aging population, is highly prevalent. Over 75% of our adult population over the age of 65 is going to have a significant hearing impairment. But unfortunately, less than 30% of those patients really receive the hearing health care that they need. So it really is a lack of education, a lack of accessibility, and some elements of affordability too, to bring hearing health care to all patients.
As you look to build this database with voice, is there anything that presently exists in hearing? As an otolaryngologist myself, you could imagine large databases of audiograms, comorbidities that go with this. And what's the state of AI and large data with hearing?
So interestingly, we are funded at the NIH under different institutes. So the Institute for Otolaryngology is usually NIDCD. And NIDCD is there for voice, communications, hearing, and balance. And believe it or not, there are no big data sets that actually combine all of these data together, which is pretty surprising. So the state of the science is sad, and there's a reason for it, right? When we started Bridge to AI, we wanted to include as many biomarkers as possible. And then, we met at first and we said, well, can we include audiograms? How would we do it? We would have to do a screening and then bring people in for full audiograms. And it's a barrier, right? Because full audiograms are not scalable to a patient population, for example, that we want to collect lots and lots and lots of data. So that's why we didn't include that right away. So then we have to think about alternatives, right, to the best standard of care, because when standard of care is not scalable, we have to turn to other technologies that exist, such as built-in audiograms within apps. And there are a lot of third-party vendors and companies that offer these products. So maybe Dr. Sanchez knows them pretty well and can expand a little bit on them.
Yeah, there are technologies constantly improving. And so we finally have some additional tools besides the audiologist in the sound booth. We're starting to be able to capture hearing and hearing function using smartphones and tablets. And there are a handful of options, a way to do that, either through like actually hearing tones and getting sensitivity measurements, or understanding someone's ability to hear speech or speech and background noise, which really brings a good ecological validity to the measurement as well. Because in reality, we don't talk in beeps and tones. We actually talk in communication. So understanding how can someone actually hear at that communication level. So there are these apps now that are readily available where people can do these tests at home in their own comfort, but also allows them to be integrated into research, which we're planning to do shortly.
Yeah, I mean, I've heard of people using hearing to try to help make diagnoses or having it be part of the cognitive evaluation. And with voice, I've heard of this as well, using the voice and probably using hearing, right, to determine maybe early signs of cognitive impairment or mental state. So how will this all work together? It seems like a natural fit, but how do you envision this all coming together and adding to what seems to be a big gap?
So I would say we're almost there. The pieces of the puzzle are there. There's another big group called SpeechDX project from the Bill Gates Foundation looking at cognition and speech. They also don't collect hearing data, which is interesting. And there are collaborators now. So we're hoping to bring that. Hearing and cognition is well studied or is beginning to be studied. Speech and cognition are also separately studied. So I think we need to be the glue to come together and say, hey, let's talk about those three things together, because hearing affects voice, which affects cognition. Cognition affects hearing. Hearing affects cognition, right? So we need to go until we understand all the correlationships. So we're almost there, I would say.
Yeah, and I think the synergy is in the collaboration, right? So if we continue to practice in our silos, then I think we're missing out and not really fully understanding our patient populations. But as Yaël just mentioned, the combination of all of that is probably going to move us forward. So to go back to the question about hearing and cognition, there is a growing amount of evidence really linking the two, with those that have more hearing loss have an increased risk of cognitive decline and incident dementia. And this has really been discussed in headlines, right? It is something that has really been bringing public awareness to it, and people are really concerned. Most people really want to make sure they hold on to their cognitive abilities as long as they possibly can. So when we have something that is connected, we want to study it more. And so there's a growing amount of evidence showing us the connection between those with hearing loss have this increased risk, but the mechanism connecting the two is really unknown. We don't know if there's a causal pathway or what's going on there, but we're also gaining some information that if we treat the hearing loss, we seem to reduce that risk, at least in some patient populations. So not only do we want to care about the connection between those with, hearing loss and cognition, but what if we do something about it, right? Because not only do we want to identify patients that need treatments, we want to see if those treatments can work. And that's why I think working together with all of the different scientists and healthcare providers can really make the biggest difference.
And maybe, Paul, I can add a little bit about how hard it is to do scientifically. For example, Bridge to AI, how we collect data is we give people an app and they have to read the questions and they answer based on the questions they read. So what would happen if we gave them the same question, but they had to hear the question? Because right now, we don't put that modality available, right? And in real life, we know that people struggle because they can't hear the questions. Well, they answer differently in how they answer those questions. So even the validity of the methodology of how we collect the data, we have to think about it, right? Like it's great to say, well, this patient is talking like this, and that's their hearing, and that's their audiogram. But the way we collect data, we're not asking them questions, but making them listen to the question, which is not really translatable to real life. So that's the whole science behind it that we have to be careful about when we implement and develop these protocols.
Yeah, I mean, particularly because no one's really doing it, right? Like you'll learn a lot from the design and then even what some of the data might look like.
Yeah, absolutely. So to give you an example, at Bridge to AI, it took us a year to develop protocols across all diseases because all the experts were saying, well, no, we have to do it this way. We have to take this into account. This confounder is important. So I think the design is really crucial. Instead of just starting to collect data, we have to think about this together with people from both specialties and really understand what we're collecting.
The barriers that existed before are similar today, right? You would be doing something that nobody has done. As the listener thinks about this, I guess, what's your strategy for implementation? I understand that you're going to have sort of an expansion of your center or a synergy of your centers to figure this out in a way.
I'm a clinician scientist. Clinicians are busy. So if you do something too complicated, it's never going to happen. So my approach is to start with a low-hanging fruit, right? And to say, well, let's implement an existing app that has been validated into all our patients. Will we get a perfect data set? We won't, but running with this for a feasibility for a few months, see what we can learn from it. And then for the patients that fail the screening, then they will have full audiograms. While we do that, we also not only assess the accuracy of the data, but the feasibility, how easy it was for the patients. Were they able to actually complete the tasks? That's really important to just start with something, because the problem is when these complex scientific questions come, people get overwhelmed and then decide not to do it. But not doing it is worse than doing it. But we have to start small. So that's kind of the beginning of our approach.
Well, and as you mentioned, as clinician researchers, we're always going to approach it through a couple different series. And sometimes it's this opportunity where good science creates more science. So we might learn things that will lead us towards newer directions, but ultimately to really just change the way that we can use these biomarkers and bring them to patients and improve healthcare altogether.
Well, I'm really excited for what you're going to do together, and I really applaud all the work you're doing down in South Florida. It's been a multi-year effort that is ongoing, and I'd encourage the listener to check out the article, but also to keep an eye on you both in terms of the questions and things that are coming out from your centers. Well, thank you both for coming on the podcast today. It was great to talk with you.
Thank you.
Thank you.
I'm Dr. Paul Bryson, and I've been speaking with Doctors Yaël Bensoussan and Victoria Sanchez about the importance of hearing health and voice biomarker research. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.